Thank you. I think you're on mute. Dr. Gill?
Yes, I'm so sorry about that. Okay, sorry, I'm on my laptop. It's giving me a hard time today.
Uh, uh,
So, what we want to talk about today is getting on medications for opioid use disorder, and really, how do we do that in pregnancy, and what does that look like? You'll notice here, I'm referring to medications for opioid use disorder. We're really trying to move away from the language medication assisted treatment, or MAT. It's really not an assisted treatment. It is a treatment for opioid use disorder. So if I refer to MOUD, that's what we're talking about, medications for opioid use disorder. And I just wanted to put up front, when you are maybe struggling with a patient that is pregnant or postpartum, that is having any mental health or substance use concerns, or maybe you're wanting to start on medications for opioid use disorder, you can call us. Like, think of it as like phoning a friend to get some support while you're actually doing this work. So that is the Mom's Impact line, and providers are there Monday through Friday to talk with you and help support you through this. If you forget anything, just remember this, and we'll try to help you through some next steps. So while we're going to talk about medications, it's really important to understand that the overall treatment for substance use disorders for any pregnant or postpartum individual, really we use a lot of psychotherapy in terms of relapse prevention. We want to address comorbid mental health conditions, prior history of trauma, social determinants of health. And we really want to do that in partnership with prenatal care, so that everybody who is a provider is on the same page, on the same team, and can be working together to optimize care. So just a general approach for perinatal substance use disorders. When we talk about medications, we are doing sort of this analysis. We call it like a risk analysis. So what is the risks and benefits of the medications? And we compare that to the risks of the untreated illness, and try to make informed treatment choices together that really prioritize that patient's preferences and values. We talk about, if you have a medication on board that works, please continue that medication, and please continue it at an effective dose. It does not do a lot of good to be on a dose that is suboptimal, because you get the risks of the medication without any benefit, and then the risks of the untreated illness. So if you're going to use a medication, please use the appropriate therapeutic dose. If you're starting a medication from the get-go, you're really looking to the past to see what's worked in the past, and that's often the medication that we're going to go to. We want to minimize polypharmacy as much as possible, and optimize therapy and other supports, and as much as possible in that overall picture. So getting into the medications, the two medications that we use in pregnancy to treat opioid use disorder are methadone and buprenorphine. We actually have some good randomized controlled trials of these medications in pregnancy, but I just want to highlight how life-saving these medications are. So what these medications have been shown in studies, and also epidemiological studies, is that when we have populations on these medications, we decrease opioid use, we decrease opioid-related overdose, we decrease opioid mortality, we decrease criminal activity and transmission of infectious disease. Like, what medication does that? That's amazing. And increases functioning, employment, and retention and treatment. So these are just, if you're going to use any medication in psychiatry, I would use these because they actually work. So let me explain the three medications for opioid use disorder. We do not use naltrexone in pregnancy. If that ever comes up, we can talk about that, but that's not what we use. But I just want people to understand how each of these drugs work. So the little yellow thing there is considered a receptor. The little ball, the red ball, is an opioid. And what's coming in right now is the drug. So naltrexone is an antagonist, completely blocks the mu opioid receptor. So if you were to take another opioid, it sort of bounces off that receptor. You don't get the reinforcing effects of an opioid. That is essentially naltrexone. We use it for alcohol use disorder as well. So for buprenorphine, we have what's called a partial agonist. That means you take that medication, it binds to the receptor, and it activates that receptor, but only a little bit. So that's really, really key. Buprenorphine activates that mu opioid receptor a little bit. And we'll talk about how it interacts with other opioids in a second. Methadone is a full agonist, and that means it's going to activate that mu opioid receptor a lot. And so that becomes really important in understanding precipitated withdrawal with buprenorphine. So moving on to that. So I think people's biggest concern sometimes in prescribing buprenorphine is that they're worried about precipitating withdrawal in an individual, and particularly in a pregnant individual. So I want to describe the pharmacotherapy and how it works so that you know how to avoid that. So the first thing to know about buprenorphine is that it has this really high affinity for mu opioid receptors. And all that means is, like, think of it as like a magnet. If buprenorphine is in the synapse and there's a mu opioid receptor and it's competing with another opioid, the buprenorphine is going to win. It's a magnet to that receptor over any other opioid. So that's high affinity. The other thing is that it stays there. Like, it is so slow to come off of that receptor. So it's binding to them, it's staying on them, and it at the expense of any other opioid binding to those receptors. And so the last thing that's really important to understand here about buprenorphine is that it's only a partial agonist. So what this curve is showing you on the left-hand side, it's the percent mu receptor activity, and along the x-axis is just drug dose. And that first purple line, the full agonist, that's like heroin or methadone or any opioid. And if I were to dose that medication, what that's showing there is that if I continued to dose it, I would get full occupancy of those mu receptors, and it would be really sedating. When you get up to that top line, that's when you're overdosing, right? So I can keep pushing that drug, but pushing that drug until somebody overdoses and dies. I can never do that with buprenorphine. And what that means is I could dose buprenorphine, I could use a partial agonist, and I could keep on dosing it, and I will only get to, roughly 40% of activity of that receptor. Okay, so what does this all mean? This means if you have a patient that is coming in and they're on heroin, they're on fentanyl, they're on a full mu opioid agonist, and you go ahead and give them buprenorphine. So I'm taking them from that really high level, that mu opioid receptor is turned on full blast. I give them buprenorphine. Buprenorphine comes in, it's like a big bully. It kicks it off of the receptor. It binds to that receptor, and then it's just going to activate that receptor a teeny tiny bit. And that change from that full opioid to that partial activation is withdrawal. Like, that is when you put somebody into withdrawal. So that's like that net decrease in receptor activity. So that's when you precipitate withdrawal. So now I'm going to tell you how to avoid that. Oh, I should also say that so I'll just tell you how to avoid it. So when someone comes in and you want to start them on buprenorphine, you need them to be in significant withdrawal. And we'll talk about the scale that you're going to use to measure that withdrawal to get them to a certain level before you give them buprenorphine. Because when you give them buprenorphine, it will actually then treat the withdrawal. The other funny thing here is that you can give other opioids when somebody is on buprenorphine, and you can actually get some pain benefit from that. But that buprenorphine is really the one that's going to stay on the receptor. So that gets confusing to some people. Okay, so going back to that risk analysis. So when I am talking with a pregnant individual who has opioid use disorder, and we talk about potentially going on this medication, we first talk about, well, what does it mean for you to not be on this medication? And we talk about that, what we know from the literature. So we know that there's increased risk of use, and with that can come infections, high-risk behaviors, overdose, and death. We know that use is also going to be associated with prematurity, low birth weight, maternal complications, neonatal abstinence syndrome or newborn orphan withdrawal syndrome, and maternal and potentially maternal and newborn separation if someone's in their active substance use. And so then what we're doing is that's sort of what we know in general. We'll sort of talk about what that is for that individual when they are not on these medications, what's happened in the past when they're not taking them. And then we weigh all those risks against the risks of taking the medications. And what we know is oftentimes people don't want to be on medications in pregnancy. They have trouble accessing these medications. And those are really very real barriers. And we have to sort of talk about those and address those appropriately. But we also know there's some risks with these medications. So there is an increased risk of prematurity, low birth weight, NAS or newborn orphan withdrawal syndrome, which, as we saw in this case, that can lengthen the hospital stay for baby. It can often separate mom and baby depending on where you're delivering. And so those conversations become very relevant. So you might be saying, well, like, okay, so both drugs, have a risk with them. And And how do we tell people about the risks of these drugs? So this is one of the best papers that we have to date that really tells you if you're going to start buprenorphine or if you're going to start methadone, here's sort of the percentage of people on these medications that will have neonatal abstinence syndrome. So with buprenorphine, it's roughly 50%. With methadone, it's roughly 70%. You can see the numbers for preterm birth, buprenorphine, roughly 14%, methadone, 25%, small for gestational age, low birth weight, no differences in other maternal complications. So that's nice to be able to give people sort of these percentages to weigh the risks. But I can already tell where people's mind is going, which is that, wow, doesn't it look like it's much better for the baby to be on buprenorphine than methadone, right? The risks for baby look much smaller for methadone. And that is actually, did I say that correctly? The risks for baby on methadone are greater than being on buprenorphine. So what do you do with that? So what I would say to do with that is choose the medication that is best for mom. And that is the medication that is most accessible, it's available, and it's going to reduce her risk of relapse, independent of how that works for baby. So that's the medication that we're going to go with, because if we put her on, say we put her, say she's on methadone, we switch her over to buprenorphine because we say, oh, methadone's better for baby, let's start buprenorphine. Well, you increase the risk of destabilization. You could potentially precipitate withdrawal. It's hard to get from methadone to buprenorphine without doing that in different contexts. And you've just exposed that mom to 2 medications. Now we have both methadone and buprenorphine, and we don't even know if it's going to be effective for her or if that switch actually lowers her risk for NAS, preterm birth, et cetera. Like we don't actually know that at all. We just know what happens if you stay on the medication. So if methadone is the best treatment for your patient, please keep them on methadone. If buprenorphine is the best treatment for the patient, put them on buprenorphine. That's fantastic. And you've got some added benefit with some newborn outcomes as well. So one of the questions that comes up a lot is, I've been saying buprenorphine all along, but as you know, buprenorphine comes as, it can be a single product, buprenorphine, which we have in the past used just in pregnancy. But most times we're talking about Suboxone, which is buprenorphine plus naloxone. So naloxone gets added to buprenorphine in Suboxone really as an abuse deterrent. It means that if I am trying to prevent people from taking Suboxone and sort of melting it down and injecting it. That's what I'm trying to do when I put naloxone in there. Because if you inject it, naloxone works as naloxone does. It's basically an opioid reversal. They're going to go into withdrawal. But it doesn't do anything if you take it orally. So we can give Suboxone, buprenorphine plus naloxone as an oral medication, and it's not going to precipitate any withdrawal whatsoever because it can't work orally. So we've had this question for a long time, like, should we be using combined Suboxone versus just buprenorphine alone? And there's pros and cons to this. Our practice has really switched over to that combination product for a lot of reasons. And here are some really reassuring data for why we're doing that and why it is an okay idea to use that combined product. So if you look at the percent of people having babies that go into NAS that are on that combined product versus buprenorphine alone, it's lower with a combined product, a little bit lower with NICU admissions, and a little bit lower for small for gestational age. No differences otherwise. So we can talk about why you do one over the other, but our practice at this point is to do the combined. Okay, so buprenorphine and pain management. This gets a little bit confusing to some people sometimes too. So you're on this medication. What do we do when we get to labor and delivery? So the first thing you do is keep them on the same dose of methadone or buprenorphine or Suboxone that they were taking in pregnancy. Just hold the dose stable. Give them the same pain management regimen that you would give any other patient that either had a normal vaginal delivery or C-section. So baseline is they get the same as everyone else. Some things that you can do to optimize pain management is you can actually split their total daily dose of methadone or buprenorphine. So if they're on 900 milligrams of methadone, maybe do 30 milligrams 3 times a day. So you can sort of split the dose, give them a little more coverage during the day. Sometimes that can help for pain control. And definitely encourage epidural and schedule NSAIDs and Tylenol alternating. So just at baseline, do that. And avoid Nubane and Stadol. Those are also opioid partial agonists and can precipitate withdrawal with buprenorphine. So we don't use those medications with this population. And just as a reminder, you can breastfeed by taking buprenorphine or methadone unless somebody is in active substance use or is HIV positive. Okay, so I think we sort of talked about this a little bit. Like there are 3 different types of buprenorphine medications you can take. Subutex is the one that's just a buprenorphine tablet. Subzolve is the buprenorphine naloxone sublingual, and then there's also Suboxone as well, the combination as well. Okay, so what we do, as I said before, you're going to start a pregnant person on buprenorphine or Suboxone. You are going to make sure they're in withdrawal, and you are going to start by using the clinical opioid withdrawal scale. They're doing their ratings. You're getting them to at least an 8 or 12, because if they are not in withdrawal and you give them buprenorphine, that's when you'll precipitate withdrawal, even worse. So as soon as they are in a significant enough of withdrawal, you're going to take an 8 milligram tablet or film, whichever one. They're going to cut that in half. They're going to take 4 milligrams and wait about 30 minutes. Tolerating okay, doing all right, no withdrawal symptoms, take another 4 milligrams, and that's what they do day 1. The next day they wake up and we have them take 8 milligrams, and you're doing that twice a day. And then you're going to continue 8 milligrams, and we'll talk about changes as we go along. But it's the same thing that you do in non-pregnant populations. You can do this outpatient. People can do this at home when they get home at night. You just give them very clear instructions. And a lot of patients know what buprenorphine does. It gets bought off the street, and they can tell you, oh yeah, no, I get you. I'm going to take it this way. So I won't go through that again. So say you did precipitate withdrawal, which doesn't happen often, but can happen. You're going to give them buprenorphine to treat the withdrawal. So you can actually give them another 4 milligram dose. And you can also add on some ancillary medications to treat some of the symptoms of withdrawal, depending on what they're having. And so that's a pretty good list there to treat all of those things that can be happening as a result of withdrawal. The last thing I would mention is that in that induction period, you are going to tell that patient that over the course of pregnancy and postpartum, because of the physiological changes in your body, the levels of buprenorphine are going to be becoming lower. And I would expect as a result of that, that you might experience some withdrawal and craving. So please tell me as soon as that happens so that we can adjust your dose. And most times people will say, no, we're not going up on this dose because that's going to increase the baby's risk of NOWS. And so we can stop and we can say, nope, actually the dose is not a predictor of NOWS. It's so counterintuitive, but it has nothing to do with your risk for NOWS. We want you on the most therapeutic dose. Relapsing will increase your risk for NOWS. Smoking will make NOWS worse. Like there's other things we can do, but the most important thing is that your craving and withdrawal is under control. And if we use a higher dose, that does not mean you have a greater risk for NOWS. I think I added a lot of data to just highlight that, which is basically over the course of pregnancy, you do actually need to adjust the medication as you move along pregnancy because of the physiological changes. This is sort of the same thing. One of the things you can do when you run into some resistance around, I'm not increasing the dose. I don't care what you say. I hear what you're saying about this doesn't cause NOWS or increase my risk for NOWS, but I'm not increasing my dose. So you can split the dose. Sometimes that can be helpful to sort of bridge somebody as they're going through pregnancy. If they're having craving withdrawal, you might take their total dose and split it up over the day. That's sometimes like a good compromise next step. What do we have here? Oh, excitingly, we will have some new options pretty soon. There is a clinical trial that will be completed in February where we used a weekly injection, Brexadi. Erin was actually the medical personnel on the study and has made more experience of anyone I know in giving this shot. So we're excited for this to be available and see how we can use this. It has some advantages to get a weekly shot versus sublingual, and we'll see what the data look like very soon. So Brexadi is that weekly injectable, but it also has a monthly injectable, and Sublocade is a monthly injectable as well. But we do not use the monthly Brexadi or Sublocade injectable because its incipient has some properties that have shown to be teratogenic in animal models. So we tend to avoid those medications during pregnancy. And of course, every patient that has opioid use disorder, you're going to talk to them about Narcan and make sure that they have access to this and that they have partners or family members, whoever's closest to them has access to this and knows how to use it as well. And I think that was it. I think I'll stop there. This is going to get too confusing. I'm going to stop here.